and what caregivers and family members might learn from Dr. Sachs. Whoops, you got to unmute.
One often hears negative metaphors. Someone is gone, they're absent, they're dead, they are a husk, a shell, and the like, because obviously they're not experiencing life in quite the same way as most of us are, productively and the like, engaged in activities. So the trick is to be a good noticer. I use that word very purposefully, to notice, to hear the whispers, to catch the winks, because the assumption should always be that there is more than meets the eye, even if someone's communication system has broken down greatly. We have no business asserting that, well, they're not there. We don't know that. We can be agnostic, perhaps, and just recognize how little we know, but there's a great mystery. I think that Dr. Sachs was extraordinary in recognizing these very subtle signs and being able to respond to them, and also to find hope in being open to surprises. One wouldn't necessarily think that you would get these moments of lucidity, for example, but he saw hints at these things, and that gave him, I think, a lot of enthusiasm about somehow freeing these individuals so that they could really unveil their continuing self-identity.
And Iris, one wonders the degree to which we can train doctors and other health professionals to show the compassion and the curiosity exhibited by Dr. Sachs. You've taken a leadership role in designing courses for medical students that shape these kinds of behaviors. Can you tell us something about the curriculum that you and your colleagues developed at Stony Brook?
Thank you. And again, I'm very happy to be part of the group that's talking about this pretty phenomenal film and inspired me to learn more about the man and about the illness. And again, it created a lot of curiosity about all the things around going on in the film. One of the things, I focus a lot on the medical students before they actually work with patients. And then Stephen can talk about something called reflection rounds that happens once they're in the clinical years. But I think the key thing is we want to keep the heart open. And what can we do, like during these first couple of years when they're learning facts at such a speed that they never imagined possible. So you're taking these very bright, many of them very sensitive students, and now just cramming so much facts into their brain that, what can we do during this time to keep their heart open? So one program we have is called Patients as Teachers. They want and they crave seeing patients. And with the course that I do now, the way it's structured is we have a week with them after each major science block. So, and we bring in a patient that represents an illness that they studied. So besides just reading a book version of the illness, now they learn about the life of a patient that's living with that condition. So in our first block, we bring in parents and doctors that are working with the patients, depending on which age group we're focusing on. So a perfect example is coming up at the end of May. They'll finish learning about the respiratory system, the cardiovascular system, and the renal system, and they learn about a disease, cystic fibrosis. We bring in an adolescent that has lived her life with cystic fibrosis and her siblings and her family, and they sit there and they listen to what this girl goes through every day just to get up and get ready to start the day, the kinds of treatments she has to do, the kinds of treatments she has to do at night, the things that she lives with. And it's like a chance for them. They love it, And again, it's that idea of keeping a connection, a human connection, and to understand what it's like to be a patient. And I think that's one of the things that Dr. Sachs focused on too. In his mind, he was trying to imagine what it was like for these patients. And that's one of the things that we do.
Can I add that in the film, when Dr. Sachs, or well, Robin Williams is Dr. Sayer, when he was involving the staff with the patients in non-medical ways, so
Right.
music and dancing and just recreating, it really made a difference, and that's been my experience in the long-term care facilities where I've worked, is when you can get that staff to be a part of the afternoon activities and really see the residents at the nursing home, as playful and really enjoying themselves. It really goes a long way to helping develop that compassion that Steve was talking about, that being a friend, being a companion in this is not just ministering to the disease itself.
To what degree is this humanistic approach something that's inherent in the young doctor, like their personality, or the degree to which it's sort of trainable? I mean, have you seen changes in some of the medical students in terms of their ability to relate to the patients?
Again, I think they come in on a spectrum. And then you have students that, inherently are very kind individuals. Maybe they were raised in a certain way to focus on kindness, and they're compassionate and they're caring, and it's there. And, these students just shine out and you see who they are. Then you might have another group of students that probably don't have great interpersonal skills. They may be really highly scientific and great in that kind of things. But what we do focus on is not just teaching them about asking the questions for a typical history. We make sure that we focus on communication skills. We focus on making sure they ask the patient, what does this mean to you? These symptoms or this illness, how is it affecting your life? And we expect them to listen, okay? And by showing them that we're not just caring that, did they get the diagnosis? We have to come back and ask them, well, how is this important to their life? We have to show that these questions that we think, what they think, we want them to ask the patient, what do you think is going on? Because then you get a little bit more into what the patient's fears, concerns could be. And then you have to make sure that you ask them and that you question them. And so that if they don't inherently think it's important, at least they're learning to ask those questions and know that they're going to need to report back on it, not just on what are the physical symptoms and signs in the disease. And I think asking them to reflect, there are some students that come in, they can't identify a feeling. We ask them to write reflections right from the beginning. And like an example, first reflection might be, what are your thoughts and feelings about starting medical school? What are some of the things that, insights you gained from thinking about your thoughts and feelings? And some people will write everything about a description about the room. We ask them about going into the anatomy room for the first time. What are your concerns? They write about everybody else. They write description of the room, but they never once say I or talk about a feeling. So I think that's another thing that we try to promote when we say self-awareness. Can they get to their feelings, and then can they express those feelings? And I think that's also going to help form a relationship with people in the future. And then Stephen, I think he should mention about in the clinical years, he was very instrumental in helping to implement that. People, once they go through the clinical years, sometimes they say they lose some of their compassion then, because then it becomes like, you have to get this job done, all these little tasks that you have to do, and then you do forget about the patient. Even though you're there, they've been waiting to take care of patients, but then they're put in a situation where it's like they don't even think about them as people maybe at that point. So can you talk a little about the reflection now?
Yeah, I think, thank you. So that, there's a tendency to get very routinized in providing care, basically, medical care, strictly in the external sense of, getting a needle in the arm or whatever it might be. But the human side of their experience is something that they need to respect and reflect on, as Dr. Granek just mentioned. And that actually needs to be a long-term, career-long habit, because when people get so routinized and they lose all of the kind of inner music of compassionate care, they oftentimes find what they're doing to be meaningless. And they can be more susceptible to burning out, having a short half-life as a nurse or a doctor. So it's really important for them to form community around their emotional experiences in response to patients and also to one another. And instead of just leaving that out in the parking lot, or maybe, bringing it up over a cup of tea at home, to actually bring that into their clinical environment in small groups, no larger than 6 or 7 typically, and to really talk about their experiences from a deep point of view. I mean, one case, I'll just mention this: a young fellow who was on medicine, and he heard a derisive joke told within earshot about a patient. And he wondered to himself, should I laugh? Because if he laughed, he would be ingratiating himself perhaps to the team and get a little better review. But he decided he wouldn't laugh. And then he asked himself, should I even smile? And he decided he wouldn't smile. So he stood there passively. And then a nurse, a really special nurse, walked up to him and said, I noticed how you handled yourself. I was really impressed. And so now, why don't you diplomatically think about approaching the team and telling them how you experienced this as a student? Which the young man, he didn't have to, but he decided to do this. And the team was very responsive. They realized that they were off the mark on this and they wouldn't let it happen again. And they congratulated him on having the integrity to express his feeling state about that particular circumstance. And that's the idea of allowing for reflection time in these clinical environments so that people can hang on to their own formation and their full human selves and not just be going through the motions.
Very interesting. Another theme of the film is the use of new medications and the degree to which we can trust that they are safe and effective. Dr. Sachs wanted to try the medication L-Dopa, which was approved by the FDA, but for a different condition, and he had to jump over hurdles to get his hospital to allow him to try it. Lory, can you explain what's involved when a doctor wants to try an established medication, but for another condition, like in the film?
Well, that's really interesting because this really parallels what's happening with us now when everyone's very concerned about how rapidly the vaccines that we have been produced. And really, it was not so much that they were rapidly produced because the technology for producing those vaccines has existed for quite some time. It was just that they needed to specify what kind of material they were going to use in the development of it. So yes, it was produced fast, but the pre-work. So we have to remember that actually L-Dopa, the medication that was used in the film, was actually synthesized in the teens in the between 1910 and 1913. So it's not that we didn't know about it, and it was used in Parkinson patients and was written about right before Dr. Sachs. That's in the movie. He looks at the articles, the literature, and it wasn't actually approved by the FDA until actually the year after, in 1970. And this was Dr. Sachs using it in, before then, 1966 to 69. But the point being is that we have to remember, and Dr. Granek was good to point it out to us as a panel, that there really is a difference between using something in practice that is approved, that has been used and known to be safe, um, and medicines that have not yet proven their worth, so that we have to research them, that we have to know, one, whether they work or not, and then they also go through safety trials, so that the drug is shown in the long haul to be safe, and it doses. And so I've participated in all levels of drug development, but these are drugs that start out, and they the poor mice and the poor rats, especially in neurosciences, have really given their lives, to learn about the brain structure and the neurotransmitters. So the L-DOPA had been shown to be useful in these patients who had Parkinson's disease. And Dr. Sachs, even though he saw that these patients that he had in the hospital there were different from the other patients he saw, the ones with devastating strokes and with dementia and with psychiatric disorders, that these people, even though they were different than others, they were different among themselves, right? That they weren't all the same. And matter of fact, there's been research looking at this viral syndrome, this post-viral syndrome that emerged in the late 19 teens and up until 1930. And maybe there was 1 million people in the world who had this kind of encephalitis, this sleeping kind of sickness, and there were different types. So he said, okay, my patients don't have the all the common Parkinson's, but they don't move, and Parkinson people don't move. So let me try it. And so he was working in a field where, at that point in time, we didn't even know how much we really should be giving Parkinson patients. Drug development and how much to give and when to give it is really the nuance of medical research. So he was um, he was treating with hopes of benefit. So he fell into the realm of using a medicine that has got some track record. He wanted to be beneficial to his patients, but he really was, I've got to say, doing research and in a very vulnerable population. But he was doing it at a time when there weren't a lot of controls in place. Um, Luckily, his hospital administration did really want him to review, and they put the brakes on it at first, saying just one patient, and then it was 6 patients, and then more, because this was a particularly vulnerable population, and it really showed in the film, because Leonard could not speak for himself. His mother was his surrogate. Now, in patient rights, we always want to assume that the person has their autonomy, that they have the rights. But in Leonard's case, he could not even speak for himself initially. And later we'll talk a little more about when Leonard did speak for himself. But I have to say that all of drug development, we have to decide what is a reasonable risk. And more in my business, especially in long-term care, there are no medications for the depression, the anxiety, the aggressiveness associated with dementia. There's not a single drug out there. There is a drug that is for the psychosis of Parkinson's, but not for Alzheimer's or vascular dementia, not anything FDA approved. So I, throughout my career, have used antidepressants, anti-anxiety drugs, antipsychotics, anti-seizure medicines. to address some of these anxious, depressed, manic symptoms that are manifest in people with dementia. That's called off-label. And more and more, we are called to task to make sure that we are addressing the fact that these medicines are not specifically created to treat what I'm treating, but my best clinical judgment is involved. And so there's been a lot of pushback in it, particularly in the last 5 years, of using any kind of psychoactive medication in vulnerable populations and in nursing homes and assisted living, things like that. So I think we're developing kind of a cycle, just as in medical school we're seeing certainly more emphasis on the humanism education and hoping that students can become better observers and interactors with their patients. We also have to know that we have to be good stewards of treating patients, and the secondary gain of all of this, looking into using medicines off-label, is that we have started to develop other kinds of interventions. And so before I use a medicine to address a psychiatric symptom in dementia, I have to make sure that the staff has helped me really outline the symptoms. What's the target? What are we really hoping to accomplish? And then have we developed a behavioral program, like you saw in the recreation in Dr. Sachs's hospital, with music, with movement, with exercise, with involving the patients in some other activity. So it can't be all of one. It has to be a spectrum of provision of care.
I just want to add to that. You know, I would also want to teach our students that they have to, again, continue to be good observers and understand how to be critical observers of the literature and understand what a study actually was able to show. And even when a drug was approved, in order to get a drug approved, they really do have to just guess a little bit at what dose they're going to study, and they sort of get a shot at it. Now, again, they have to then look at the paper if they were going to be smart to say, how old were the people that were given this drug? What was the average age? Were there men? Were there women in the study? And then the patient in front of me, how do they fit into this profile? And maybe I'm not going to start with the recommended dose. And if they listen to their patients, they might hear patients say, well, I tend to really react to very minor doses of things. And I know in the old days, people would say, oh, they're crazy, you know, that's a placebo response. You know, they really can't have that kind of effect. There's no reason why they might not have that effect, because we don't study a range of doses in human beings. We pick the dose, we get the thing on market. The whole thing with L-DOPA too and Parkinson's disease, I think in the beginning people didn't understand that longer term use in people with Parkinson's disease, and as you continue to increase the doses and changes in the brain continue to happen, you get the risk of these additional movements. And some people like, you know, Michael J. Fox, he doesn't want to be locked in. So he takes the higher doses, what he needs, but then it creates the movement disorders that he has to deal with. So it's such a delicate balance. And like Lory's saying, it's great. We need to find other things that we can use, but then also using medicines perhaps in a way where you're very sensitive to the person that you see in front of you and being that fine tuning and adjusting. And what's important to the person. Like with Michael J. Fox, it's more important that he can move even if he has extra movements, whereas other people might be less important to move so much.
Well, and speaking to somebody like Michael J. Fox, who is very visible, and so most people have probably seen him at one time, he's not bothered by his movements as the observer is. We are bothered by it, and he's just enjoying that fluidity of movement, and the damaged brain, the brain that is damaged because of trauma or stroke or dementia, Alzheimer's type dementia, they might be leaky. And so lots of things get into that brain that wouldn't get into that nice, healthy brain. And you bring up a great issue, Iris, is the fact that women and older people have not been generally in studies, that most of the information we know about drugs is really about that 18 to 65-year-old man, because no drug company wants to risk treating a woman who could indeed become pregnant during a trial. You know, the world has experienced what can happen when pregnant women take medications that can affect the fetus. So
Yes.
protected populations are protected, but then we don't know very much about them.
Right. And it is over the last several years, decades, there has been a change where the NIH requires, in order to fund things, research, that you have to include women, and that you
Right.
have to, not exclude various groups. But there have been plenty of drugs that already have been approved that weren't previously studied. And some of the examples were things like sleeping pills, that the dose needed to be much, much lower in women, and they were getting very bad side effects.
On this matter of drugs and music and other interventions that are non-pharmacological, I think, Dr. Long, you made a very good point about this having to be a combination of things, because it's so often, not too long ago, I was in Brooklyn at the Memory Center in Brooklyn Heights, and they have Alzheimer's poets who do this full time. And there was a room of about maybe 25 people with quite severe dementia, heads down, not communicating with one another. And then this fellow in the middle of the circle begins to read Robert Frost, The Road Not Taken, which is something that they would all relate to given their generation. And he would do it with energy and singing it at times, and then he would engage them. And I would say that 80-90% of the people in that room chimed in. They may not have remembered the whole poem, but they were repeating lines, and they became animated. They came into themselves. They were expressing emotion. And suddenly you could see that there's an aliveness inside. They were alive inside. And no drug can do that. I mean, what we have, maybe you get a little benefit in certain symptoms, attentiveness to tasks, or maybe a little boost in word finding for a while, but nothing that can kind of bring these people back into themselves, like poetry or like music.
Mm-hmm.
And I think that's the thing that we need to be sensitive to. As again, Dr. Long pointed out, and as Dr. Granek pointed out, these are people who are still there, and if you notice and if you make the effort, you can connect with them in these various ways. I knew a guy in Kansas City who went to an art therapy class for people with Alzheimer's, and he was quite severely demented. And he would draw the same. It was a pencil on paper sketch, but in the middle of the sketch there was always this. It looked like a tree trunk. Okay, always, right? It was always there, and I couldn't figure it out. And I would ask him, Joe, what's that mean? What is that? And he couldn't respond at all. And then I asked him one morning, so Joe, what is that line you keep drawing? And you know what he said? He said, it's a map for my daughter to get to my house.
Oh.
And so you just never know, and you have to give them the opportunities to be creative, because even though their linear rationality may have faded, their symbolic rationality is still there. They're able to relate in terms of symbols and environment and consciousness.
And in the other aspect, we're talking about Parkinson and movement disorder, they found things like dancing.
Mhm.
And you can get, there are now programs, they have at Stony Brook, dancing with Parkinson's disease. I could see with my own boyfriend who has it in his facility, they put on, and he's in Mexico, so they put on some Mexican music, and people that were just sitting there get up,
Yeah.
start moving. He can all of a sudden be tangoing. And he doesn't think about it, that he can be changing position. And afterwards, like he think, oh, because he's not even thinking it's doing something in the brain that's enabling him to move. And then there's a program called Fight Back Against Parkinson. And that's where they have boxing. And again, you see people that normally can't move that all of a sudden they're like rhythmic doing the boxing, or they're doing different kinds of walking that's related to the exercise. And they do the throwing the ball and catching the ball, and it just happens more automatic, tapping into something in the brain.
That's right. I had a patient's wife who her biggest complaint about her husband who had dementia was that he never spoke to her anymore. He never has any conversation with me. And so I convinced her that he needed to also have some socialization. So I convinced her to take him to daycare. And he went to daycare, and he'd get home at night, and she'd go, "What did you do?" And he couldn't tell her what he had done during the day. So she went to pick him up one day to take him to a doctor's appointment. And as she came into the day program, he was singing away with the folks. And she came back and she goes, "I told you, doctor, that he can talk, but he just doesn't want to talk to me." And once I told her, our singing language is in a whole different place than our talking language. And she said, "Oh," and I said, "So why don't you sing together?" And they started doing that. And by gosh, she said, "He sings back to me."
And I think that's the beauty, so well stated, Dr. Long, that's the beauty of music and rhythm and movement. If you think about human evolution, neurological evolution, truly rhythm and music, drumming, those kinds of dimensions of experience go back so deep, and they're so profoundly a part of our core. We get away from them sometimes in our busy lives, but in a sense, they're disinhibited. I would almost say, in some of these patients. It sounds like Dr. Granek, that Elias, your significant other, that he's disinhibited, and when they get somatic, I think their memory comes back a bit, because a lot of memory is somatic. It's not just, non-physical. And that's why people can remember a musical piece sometimes that you would assume that they could never recall. But I think that there's a lot to be said for the whole self, rhythmically and musically, and the dancing programs around the country. The Alzheimer's choir movement, which is coast to coast, I think is just really cool.
Okay, let me switch gears a little bit. And another interesting part of the movie was Leonard's desire to take a walk on his own on the hospital grounds after his condition was drastically improved. And the hospital board rejected his request. He made quite a stink about that. Lory, can you talk a little bit about the issue of balancing patients' rights versus the accountability of the institution? Really an issue of patient freedom versus safety.
This has been for all time, ever since we had great large institutions to protect people from themselves and protect others from these people who were indeed depressed, manic, psychotic. There's been a very also long legal kind of history of people getting the rights to do things. And matter of fact, New York has been a leading state in patients' rights. There's no irony in the fact that New York also had the largest number of institutionalized psychotic or mental health patients in the world, and here on Long Island, especially in the three major psychiatric hospitals. But there was, but there's always been this unknown. How can we protect Leonard? Because at the point where he was so unpredictable. He seemed to be doing just fine, and yet his tantrum over not being able to go out showed us that he still, when stressed, perhaps would not be able to either protect himself or the people immediately around him. So it's always been a real difficult time, and that's why there is the specialty of forensic psychiatry, and even your best forensic psychiatrist is going to tell you that how can we predict the future? We can say that we've watched an individual for a period of time, they're taking their medications, they're doing well, but how much freedom can they give? And I shared with you that in the nursing home where I have patients who live there and are watched by staff, I always felt very secure. But my outpatients who came to me, and then I had to send them home, and sometimes home with a frail spouse or minimal outside supports, and so you make your best judgment, and that's the best you can do. In Leonard's case, he had his mother, who was somebody who was really important. So I don't think the movie was long enough for us to really know, kind of each step that they could certainly go through with accompanied, and how well he does with one person, and how how many stressors he could tolerate. But it was very heartbreaking because we're all rooting for him. We as the audience, I really wanted to take myself out of the professionalism there. I wanted to root for him to be able to go out and have a successful, time out.
Okay. Also, Dr. Long, I was struck with the wide range of diagnoses that Dr. Sachs' patients were given. It was atypical this, atypical that. What's the function of diagnoses in psychiatry if the seemingly same disorder is diagnosed with such different labels?
Yes. Welcome to my world. In the fact that diagnosis of anything, whether it be a cardiovascular diagnosis or a pulmonary diagnosis or a mental health diagnosis, helps the physician talk with the patient about palliative treatments, about curative treatments, about future, all the kinds of lifestyle changes that may accompany this high blood pressure or this diabetes or this pulmonary problem. In mental health, the Diagnostic and Statistical Manual is in its 5th incantation. I always thought that the reason they had a new one was because the American Psychiatric Association needed a little more cash, so they would produce it. I'm sorry to sound cynical, but what's really wonderful about this last one is that it sees mental illness in spectrums, not in little pigeonholes, but spectrums. And so the reason that he found so many atypicals was, one, I told you that there were that particular virus, the encephalopathic changes that these people had, affected every individual a little differently. I always say, you see one person with dementia, you've seen one person with dementia. I can learn from that person and hopefully, gain some information and how best to treat another person. But that person comes to their disease with all of their own experiences, with their own losses, their own reserves, their own supports. So in those particular people, they may have had different parts of their brain affected. So their presentations were a little bit different. So they had atypical psychosis because they were having outbursts or they were having psychosis, delusions and hallucinations. Some may have just been unmovable, and so they got that diagnosis of catatonia, but no one could figure out why. So then we put atypical because that means that we're not sure why. And so in psychiatry now, it's really nice because we've kind of gotten a balance between the lumping of diagnoses or symptoms and that splitting of all the little hairs, so that people now can have more than one psychiatric diagnosis. It used to be, if you had substance abuse, you couldn't have major depression, because if you were an alcoholic, by gosh, that was the root of all the things that were wrong with you. So you couldn't have anything else. Well, that's not true. They live hand in hand often, and we don't know which sometimes comes first. The depression, and the person then medicates themselves with drugs or alcohol, or is it the drug and alcohol use also triggered by changes in one's brain and drive for this, and the feelings that those drugs and alcohol give to that individual person. And then comes the crash, the depression, the anxiety, all the other symptoms that go with it. So it is, psychiatry is that last kind of bastion of the art of medicine, because the brain is giving up its secrets very slowly. It's keeping itself close to the chest. It doesn't want to tell us everything all at once. It wants to keep its secrets, I think, for a while. But we are coming an awful long way to understand how things do work with how the brain uses certain chemicals. But we only know a tiny bit about the chemicals that we do produce.
And I think nowadays, right, there would be less use of that term atypical.
Right. Yeah.
Yeah, they might have say
But
not
they really
otherwise
didn't know what they were
specified.
working with.
Yeah, we don't use the word so much atypical. But
Well, because they didn't have
right.
the test to help them understand what they were working with. Now, we are very fortunate that now we can actually see exactly how much dopamine a person is producing, or if that person's using the dopamine that they're using. So so somebody is not going to be given L-Dopa, or a combination of drugs. They're not going to get a dopamine agonist, if indeed they don't utilize it. Because some people, it's not the production, it's the receptors and how the body uses it. Just like the difference between a type 1 diabetic who doesn't produce insulin and a type 2 person who may produce lots of insulin, but their body doesn't use it properly. And so you certainly don't want to give insulin to a type 2 diabetic who can't even use the insulin they make. And that's often what happens with people with psychiatric disorders, is that we say, well, they seem depressed. let's give them some serotonin. Let's give them some norepinephrine. Let's give them some dopamine to rev them up. And the point is that their brain can't use it well. And then they have bad side effects.
So my quick response, Joyce, to your query about the different manifestations that you see in those patients. But I'd love to hear Dr. Long and Dr. Granek comment on this. Nowadays, I hear the expression mixed diagnosis a lot. So there can be, taking this theme of many different things going on in a person's brain. I mean, some of these people, who knows? I mean, maybe they had chronic traumatic encephalitis when they were youngsters. They hit their head too many times playing ice hockey. Maybe in midlife, some of them had little stroke events in the white matter of the brain. So they actually have what some people call multi-infarct forms of dementia on top of the encephalitis. Maybe there are all kinds of genetic susceptibilities that differ greatly. And so I think that a lot of times you in these individuals, you have to assume that each one of them is unique and bringing a whole set of issues to their experience. And so they don't all look the same, and you wouldn't necessarily want to think that they would be. And with Alzheimer's, I mean, so much of it now is considered mixed. And where do we go with this? It's very complicated. I don't know if that makes any sense.
No, I think it does. And then also, again, they're looking at he came in and saw the patients at various stages in their lives, in order to a lot would depend on how well, and then people were not as good note takers as he was. What was the observation when these people first were admitted to the hospital? How old were they? What was their past medical history? Right. And again, reading articles about this form of encephalitis, there were several different versions that people were showing up with it. And then how it was acutely, how it became chronically. So there was many manifestations, and that's the thing we talk about, is that sometimes you try to give a diagnosis, but it really is very, very varied in how it's going to present itself. And it might be more than one thing going on, for sure.
Yeah, the language I love in the DSM, the Diagnostic and Statistical Manual, is otherwise unspecified.
Right.
Which means we don't really know, but it kind of looks like this.
And thank goodness, we're using a lot of that, less of the NOS, not otherwise specified, these days. Because now we are allowed to give more than one diagnosis. We are allowed to see a spectrum of symptoms. So I think that's the good part of the fact that after 27 years we reevaluated our diagnoses.
And in terms of the research front, especially at Stony Brook, the current chair of psychiatry, one of his areas of research is that whole looking at brain activity. And is there ways that we could begin to look at people with different syndromes, manifestations, symptoms, and then actually see their brain? What part is active? What part is inactive? What happens, when you're talking to somebody, you can see which parts of the brain light up. And the hope would be one day to be able to use this very complicated analysis of the images of the brain to come up with what pattern fits with what kind of diagnosis, or at least not even so much a diagnosis, but what medication might be most effective for that particular patient.
Well, just like in the 1950s, we were promised flying cars by, the 1980s. We were all going to be flying in DeLoreans by then. Well, I went to medical school in the 1970s, and I was sure that by the time I became a psychiatrist, that I wouldn't be diagnosing somebody with depression. I would be diagnosing them with a serotonin deficiency, a norepinephrine deficiency, a hormonal deficiency leading to, mental health issues. And we're on the verge, but we're still some ways from that. So maybe we'll get that in flying cars at the same time.
I kind of think, just guessing here, that as we use brain scanning, PET scanning, and so forth, for more and more of these patient categories, when people, for example, have these awakenings, if you will, whether it's music and memory or some other such intervention, we might be able to actually figure out what part of the brain is kind of bringing them back into themselves. And then you could think of ways maybe to do deep brain stimulation, which is not pharmacological, but they use that in depression these days, and it's somewhat successful.
Right,
So
it's
I
a movement
like that
disorder.
idea.
Right, and part of Parkinson's disease with extra movement.
Yeah,
Right.
yes. Yeah. So I think that's really promising, and some great institutions are doing good research on it.
There's
Yeah.
some really beautiful pictures on the internet of brains on meditation, brains on while they're walking or after, like before and after a nice brisk walk, and on music. So, our brains, our cortex just light up. Even when we're just thinking about words, we have parts of our brain that just light up.
Right.
Not to mention us really listening to words or speaking words. So, yeah. So our brain needs to be used. It's a very complicated muscle.
Well, all of this sort of illustrates the mysteries of the human brain, and we've come a long way, but it's clear we have still a ways to go before we get the precision that I think we all would like. I'd like to thank you all for sharing your time and expertise on these very important topics. Really appreciate it. It was great to see all of you again, my Stony Brook world. And,
Nice to see you.
I'd like to thank you all too very much. It was a pretty exciting topic and talk that I don't think until I listened to you all, I was really even any part understanding how you were going to cover this these topics from that relate to the movie and to modern psychiatry and neuropsychiatry especially. Thank you so much. Thank you all from the Rosendale Theater and from me. Just want to say before we close that the Science on Screen program is an initiative of the Coolidge Corner Theater with major support from the Alfred P. Sloan Foundation. And we're grateful at the Rosendale Theater to be part of this program, to be able to present really great programming like tonight's, and would like to keep the discussion going in many different ways. I'm sure that if you're a student or just an interested person in medicine and in health, that you're reading all kinds of literature out there. And I think in the context of tonight's discussion, all these things get clearer and more interesting. So thank you all so much.
Thank you.
Thank you.
Thank you.
Pleasure. Thank you, Joyce.
Thank you.